Good afternoon. Good afternoon and welcome to the meeting of the Health and Wellbeing Overview and Scrutiny Committee on the 5th of April 2022. Have we started the live stream? Yeah. Just to remind you that this meeting is being live streamed and can be viewed on Northumberland, YouTube on northumberland.tv. Please make sure you switch your mobile phones off or onto silent. And we'll continue. Apologies for absence. I've received Councillor Vilchek's. Any others?
Yes, Chair, we've got Councillor Humphrey and Councillor Patterson.
Can you turn on? Right. So the next item is the minutes of our previous meetings. We had two meetings quite close together because of a change of date. So we have the minutes of the meeting of the 15th of February and the 1st of March.
Move acceptance, Chair.
Thank you. Can I have a seconder for that?
I'll second it.
Thank you. Disclosure of members' interests. Have anybody any disclosures on this agenda? Councillor Ferguson.
Yeah, on agenda item 8 on the presentation on slide 12, it mentions about the pupils rollout, which is something I've been quite heavily involved in my role for Northumbria Healthcare.
Thank you. Thank you. Any other disclosures of interest from councillors or officers? No, right. Forward plan. The only thing that's on the forward plan that would affect us is the dementia services, which I think we've already arranged to bring to this committee to see how it's progressing at our meeting in December. Yeah. Okay. Right. Where am I? Minutes of the Health and Wellbeing Board. Has anybody these are brought to us for comment. Does anybody have anything they wish to say about the Health and Wellbeing Board? No. Okay. Thank you. Sorry, I'm working across to. I should have said that at the beginning. So we've got a slight change to the agenda now because the North East Ambulance Service aren't able to attend. So we've just had a change around of the agenda. So we're going to move straight away now into the Rothbury update. Can I ask now for the presentation from, is it Dr. Perez? Pace, sorry. Thank you.
Thank you for the opportunity to do this. I'm Paul Pace. I'm a consultant in Northumbria Healthcare Trust, and I'm a clinical lead for community services. And I've got my colleagues with me, Marion Dixon and Terry Crichton, and we together are responsible for developments around Rothbury within the trust. So I think what I want to share with you is our proposal, and it's trying to achieve three things. The first is to meet a need for the residents of Rothbury and the surrounding area around delivering alongside the community services that we do, the ability to have some health NHS beds there, but also crucially some residential care beds which currently aren't there too. So what I'm going to do is just describe how we've got to this model and some of the key features of it. The third aspect that we're trying to do also is to deliver more jobs, and that's an important effect of this. So to put it in some context, you'll recall, and the team have been before the committee before, to talk about our proposals, and the beds in Rothbury were originally shut in 2016, and since then a number of people have been looking at how we can develop proposals for the community in Rothbury, and so we've been working up new models over that time, and the last time we came to you we were proposing a community hospital model, which was about having one team that looked after people in their homes, largely with beds as a backup, and that was to try and deliver both for their therapy needs and their healthcare needs too. That would have involved a flexible bed model, and we were working on estates issues and starting to recruit teams to deliver that. So that came before OSC 2 or 3 years ago. We had some challenges. We had some challenges around recruiting staff, But I think, and we were working through some of those issues, but then COVID came about and that really put on hold those proposals and that model of care. So a few things have happened since COVID. I think we recognise that things can change quickly and that we need to be a lot more flexible. We also, through COVID, have been managing more people in their own homes, and they're a lot clearer that there are people who definitely need to be in hospital beds, but we can manage more people in their homes. And so when we're thinking about bed models, we need to be much more flexible in our thinking about how that would operate. So the last point on that slide is that we've been auditing throughout this period about the number of residents who live in Rothbury and the surrounding area and how many are in hospital beds, both acute hospitals and community hospital beds at any one time, and which of those might benefit from if we had local beds. And I think the biggest conclusion to draw from that is the numbers fluctuate, and so therefore we need to be flexible in our thinking around it. So we now have a model that we're sharing and have previously worked this up in partnership with the local community, and we've got some representatives here and are really grateful for input, patience and support throughout this process. It's not easy coming up with what we think is quite an exciting model now, but we're working in partnership with People First Care, and the idea behind that will be that we will have beds opening in Rothbury Hospital, and those beds will be that combination of residential care and NHS hospital beds. And it fits very much with the direction of travel across Northumberland in terms of what we're trying to do, particularly around intermediate care, the drive towards having more people who are medically fit but need extra help being managed more locally, ideally in their homes, but where needed in intermediate care beds. And so what we hope from this model is that it provides a community-facing model, a team that is working both into people's homes but also into Rothbury Hospital. It can manage people in the hospital beds where they're needed to for health reasons, but particularly that we can deliver on providing residential care beds, which is a new feature of this model. So the residential care aspect of it will be to provide standard, if you like, residential care to the people in the surrounding areas. But we also clearly, because we're doing this as a joint venture, where people's needs change, we'll have our community health teams available and ready to provide extra support so people can remain in that residence, particularly we're thinking about people who might be approaching the end of their lives without having to move them. So People First Care will be the registered provider. Some of you will be familiar with them. They have a residential care facility in Wooler, and that gives some scale to it and an ability to work between the two settings. And so there's a bit more detail on the slide, which I won't go through, but there is refurbishment work that they're looking to do to make the rooms more appropriate for people to live in on a longer term basis. The NHS bed model will be for three main groups of people. So those who are approaching the end of their life, and those who require a period of recuperation, and for those who might need a longer period of time for rehabilitation. And it's worth just bearing in mind, and it fits with the rest of Northumberland, that what we have been doing over the last 2 years particularly is building up our community service to be able to manage rehabilitation and helping people to recover and regain fitness in their homes with the backing up of intermediate care beds. So this complements that very much. The community teams who are there will be providing the extra care and nursing needs that are required alongside the Rothbury practice, who will be providing GP support for people in those beds. So this is very much a partnership involving a number of organisations and a number of key people. We don't have a fixed number of NHS beds. There is an envelope of 12 beds to begin with, which will be split between the residential care and the NHS ones. And we'll keep it under a close review as to how much are they utilised, how many beds do we need, what are we using them for, are we managing things as effectively as possible. So we will have clear admission criteria. Those admissions will take place from either people's homes being admitted into the hospital or for people who are in hospital going out to Rothbury to be closer to home. The thing that is really clear, it's a new model, it's an exciting model, but it will be a model that needs to change, and it will change. And so the review and evaluation is really very important. We have a number of aspects that we'll need to be looking at, from the number of admissions, the reason why people are being admitted, how long they're staying in, how effectively we're managing their needs, and what's the experience like for people who are there in those beds. So those will be done in partnership with the CCG and also with the Clinical Senate more regionally, so that it can be robust. And we want this to be a beacon of excellence of how you can manage in small rural communities, coming up with flexible models that can meet their needs. So what we hope is that there'll be a number of benefits, that those beds are there in Rothbury and they're being wasted at the moment. So we want to utilise that. We want to provide an integrated model that is not either residential care or NHS care. It can do both, but that it also integrates with us, actually, and trying to manage more and more people locally, particularly in their homes as well. It meets a number of needs. We hope that it, as well as providing that model, will be good value for money, that it will provide a good experience for people, and that we're bringing new opportunities to Rothbury too. And I think the population, the community, has been very clear in what they feel is needed there, and we're trying to address that need too. So we've established a Rothbury Board. We've got an operational group. We've presented to the CCG, and we've been working these proposals up with the team there alongside People First Care and Rothbury Practice. And so we've got agreement around that. We have recommendations around beefing up the review of the model, which we will do. And as I said, the CCG will do that in partnership with us. We're currently doing some refurbishment work to make sure that the rooms are as good as they can be. And then the other bit is, crucially, just making sure from People First Care's point of view that they've got the staff there to manage the beds. We have the community teams in place to do that, and Rothbury Practice are ready to go. So we're just waiting on the final buildings works and recruitment for People First Care, and then we will be ready to go. So that's it, really. I think we are both nervous and excited about the proposal. Excited for obvious reasons, that it is a new model and one that's been long in the development and waiting, and I appreciate everybody's patience in us getting to that point. But I think we now have a model that feels sustainable and which hopefully meets the population's needs better than previous models have. Thank you.
Thank you, Dr. Space. Councillors, do you have any questions? Councillor Hunter.
Yes, thank you for that. It sounds very exciting and way forward. Are you keeping the local member involved as to the updates of where you are? Because usually as a local member you get the first protocol. And have you got flexibility that if you find that the 12 beds isn't enough, that there's maybe some capacity to take forward in the future? I presume that's part of your review.
Yes, so in answer to the first question, Councillor Bridges is part of our steering group and our board that oversees it. So very much that board is a combination of stakeholders, and he's very integral to that. The beds, yes, I think there's probably two aspects of that will be needing to be reviewed. One is the total number, and the other is the balance of residential care to health. And potentially there is scope, it would need some work to increase the number of beds.
Councillor Dodd.
Yeah, I think there's only yourself and I who can probably go back to when this was an extremely hot potato. The Rothbury issue. Now, I'm happy that it's somehow been resolved and that everybody may be happy. I may have missed it, but when will the doors open properly? And is this guaranteed for a long time? Because Rothbury, probably a little bit like Wooler, is a remote community. I know when you get storms, it makes it even more remote. Is this a model that you're going to follow in the future, or is this just a one-off? Because there was a big campaign on this, so I just wondered, because it couldn't be found, now it can be found, and I just wonder, is this sustainable?
Well, I think the reason we are excited about this project is because I think we think it is sustainable. I think when we were looking at models which were either about NHS beds or potentially residential care beds, it doesn't meet the total needs of a relatively small population, whereas this has a lot more flexibility to it. And it does very much fit with developments like the Bluebell unit that we've opened, where we're trying to look at how do we provide mixed types of beds in populations. So we are committed to it, and People First Care see it as a natural extension, really, of their Wooler development and their experiences of working in rural populations. I think every population is slightly different, and so the model's going to need to be slightly different. But the idea of partnership, about having flexibility of being able to move teams, the clinical teams, between patients' homes and bed settings is absolutely integral to what we're doing and part of our strategy going forward. I don't know if you want to add anything.
Any more questions, Councillor Hill?
Thank you. And all these things we're always trying to jargon and buzzword bust between all this. It's not too bad, this document, compared to some we've read. I was a bit, first of all, curious on page 5, where it says what we've learned from COVID. Medically fit people should not be in hospital beds. Did it take COVID to come to that conclusion? Because that's slightly strange. I thought that would always be the policy. And why, otherwise, you saying before COVID there was a lot of bed blocking. That's my first question.
Well, I think it's reinforced it. I think what is sometimes hard is for everybody to believe that, and I think sometimes I never really like the word bed blocking, but I think when people feel safe in hospital, as patients and family members particularly, it's quite hard sometimes to convince people that being out of hospital is a better option. But I think COVID has reinforced that. It's not a new message, and our whole direction of travel over the last decade has been around trying to keep people who don't need to be in hospital outside it. I think it's just getting that agreement between both patients, families and providers of healthcare that actually we all agree that people are medically well enough to be outside hospital and can get an appropriate care. And so. Right,
okay. And the second question, it follows from what Councillor Dodd was saying. All this talk about flexibility and it's innovative and all the rest of it sounds great. It does slightly lead to nagging doubt, thinking, is this going to work? And there's this talk of flexibility, and is a suggestion that this is a trial and it might not last. On that note, I presume there's a contract with People First. How long is that contract?
So we haven't got the details of that, but we can furnish you with those details. They're currently being worked through because we've still got the building works to complete and the time to start that, but that is been in hand.
So if it's, say, 2 years, then the whole thing would be reviewed again after 2 years, and the threat could come back in 2 years' time, depending on the length of the contract.
I think it's our commitment that this is a long-term plan, certainly from Northumbria's perspective. and utilise those beds. So the number of changes that we've made, we don't see those as short term, but the evaluation of the use of the bed is going to be crucial to that going forward. The ratio between NHS beds and residential care beds. And that's why we want to do it quite closely in partnership with our clinical colleagues in the CCG and the clinical senate as well, to make sure that we've got the right people in those beds from an NHS perspective and the demand from a residential care perspective. Our partners, People First Care, are confident that there is a need in that area for residential type level beds, including respite beds at social care level. So they're confident to go into that marketplace.
I mean, obviously you can't say because it's been negotiated, but roughly, do these things tend to be 2 years? Do they tend to be 10 years? What is the ballpark figure for how long the contract's likely to be?
I'm afraid I don't have that detail here at the moment.
Have there any other Councillor Nisbet?
My question is on page 4. It's about you've recruited the clinical lead, but you're struggling to get some support and staff to go with it. What will happen if you don't get them? Because I think it's always a big problem around recruiting like nurses and all medical care, you know. It's what will happen then? Will it just fall flat or?
So that was relating to the previous model that we'd worked up, that we'd recruited to the clinical lead, so a community neighbourhood matron model, and we were struggling to recruit to the nursing and physio model. Going forward, People First Choice have done some testing of the market to see if they could attract people to work to support the residential care beds, and they were very, very pleased with the amount of people that came forward to an advert that they put out. So they're confident that they can fill those staffing levels to be able to staff those patients in the residential care part of the home. We, as from a trust perspective, we've got the clinical neighbourhood matron in. We're also recruiting to another community nurse to be able to support that model, and we haven't had a problem filling that post.
Thank you.
Any more questions? Councillor Bowman? Oh, you're hiding behind there, so just wanted to check.
Yeah, thank you, Chair. I was thinking, I didn't put my hand up, by the way, but just a thought that came to mind. I'm aware that we're talking about an isolated village and community, but I was thinking about the bigger picture, where access to the hospitals in South East Northumberland, that's Wansbeck and Cramlington, that's still on the cards. That's still the big picture, that those who need that specialist care still get access to that specialist care. So the Rothbury situation, can you explain how that fits into the bigger picture? What sort of clinical care do you actually provide there?
So I think it's a really important point, because I think one thing we've been very clear about throughout this process is that those people who live in Rothbury who need acute care and more specialist care need to be in one of the acute hospitals. And so what we would be looking at is that some residents who would be admitted directly from the community might be those, say, who are approaching the end of their life, who where a decision's been made that is the plan of care, and they're going to be managed in the local community at home, or if needs be in those beds. So we would anticipate that a lot of these would be planned admissions where the local team with the GPs know those patients and know that if there's a deterioration or a change in their needs, that they would get admitted there. The other route would be that those people who've been admitted to hospital who are from within a wide catchment area around Rothbury, if they need, as part of our hospital discharge services, we're always looking at where are people from, what are their needs, and where would those needs best be met. So if Rothbury Hospital is the right place to do it, we would do it that way. But that doesn't, it complements, if you like, really the pathways that exist for people who might have a heart attack or stroke or something that needs, you know, much more urgent treatment for that.
So I've got a couple of questions myself, is that all right? In your last presentation, your last slide, you mentioned that you'd presented to the CCG Management Board and the Public Board, and both had approved with recommendations. Could you just elaborate on the recommendations, please?
Yes, they were very much around the evaluation side of it, and so it was about just beefing up, well, two things really. One is to make sure that we do that evaluation in partnership with the CCG, which we will do, and that was one of the requirements. And the other was also to involve the Clinical Senate within that. The Clinical Senate, if people might remember, had been involved in an earlier review of the model previously, and so it was felt that it would be helpful for them to also look at this.
Thank you. And my second question, you mentioned the Rothbury Board and Operational Group. You've already mentioned that Councillor Bridget's included. Could you just ask who else, you know, what does that board involve, please?
Yes, so it has a number of organisations and individuals represented on it. So the people who are going to be delivering the model, so that's People First Care, the Rothbury Practice, Northumbria Healthcare Trust. It has CCG involvement. It's got the councillor on it. It's got the Rothbury Campaign Group represented. I think that is probably everybody who's there.
Thank you. Claire.
Thank you, Chair. Just to reiterate what Paul said at the beginning, and I think we shouldn't underestimate it, is just on behalf of the Trust to thank the community, the campaign group and the local councillor, because it has definitely been a long slog, it's fair to say, probably some years to get to the point where we got to, and it's very easy to forget to reflect, and it's important that we take the lessons from that. But when we first started the journey in Rothbury, actually what the community were asking for was a solution between both NHS and residential, or respite. And I think actually the solution that we've got now feels like very much an exciting solution based on what they originally asked probably about 5 years ago now. So it's going to be really interesting and exciting to follow that journey as it's implemented. But really on record, just to thank the local community, the campaign group, Katie and Chris are here, and Councillor Bridget, because they've been very patient.
Thank you, and you just led me to where I was going to say is, would you like to say anything about it? You're here as observers, but if you've got anything you'd like to just share with the committee?
Thank you. I'm Katie Scott from the Save Rothbury Community Hospital campaign, and yes, Councillor Dodds, I remember you well. I remember quite a few of you actually, and we have been through it, haven't we, for the last 5 years. And the councillors very graciously and very, you know, you helped us a lot with these scrutiny meetings, and you got the whole proposal sent to the independent reconfiguration panel, which was stunning, because not many campaigns managed to achieve that. We were so grateful for you for voting for that. It was an awful meeting, do you remember? I'll never forget it. It was amazing. But we've got to hear, we were excited about the flexible model pre-COVID, but we were always a little bit flaky about it, to be fair. And then the COVID happened, didn't it, as Paul said. And then, as Claire's just said, the end result appears to be just what we'd been fighting for from the start. And I have to say, originally, when we talked with the CCG at the very, very start, there is no way they were having anything to do with residential care. They said it was impossible. So we never formally argued for residential care because we believed them. But here we go, 2022, and miracles happen. So we are pretty pleased, and we just hope it works out. And thank you for allowing me to speak, Chair.
Welcome, and I think we all share your sentiments there. So thank you for coming. I'm going to still move the agenda slightly. So we're going to follow. I don't know if if the people who are here for Rothbury, you know, you're very welcome to stay, but you don't need to. We are going to move on. So I'm going to move on now to the quality accounts from Northumbria Healthcare. It's yes.
Does that work? Oh yes, excellent. How do you move the slides on? There we go, Paul. I thought there must be a device somewhere. Hello, I'm Jeremy Rushmer. I'm Executive, thank you, Executive Medical Director. Yes, we're on the right slide. And I'm here with our new Patient Safety Director, Rachel Carter. It's going to be a bit of a double act. I'm going to do last year's results and she'll talk about our plans for next year and a little bit about the... Is that still? Oh yeah, that is still working. So thanks very much. I've been here, I've been to this a few times. It's nice to be back amongst friends. I don't think I've been for a couple of years as a result of the pandemic. But the process is highly specified, and it is nice to be reminded by something that isn't in our quality account for next year, so that we are innovating across a number of fields that don't get included in the quality account. We do a lot more work, but we do have to select certain topics to publish in our quality account report, and we, as part of that process, we consult with all of our staff, our governors, and I'm here today to consult with you as stakeholders. The process isn't complete. I am going to skip through some of the stuff that does repeat itself. So this is part of an annual planning process. This is the 4th year of 5, so we'll go through next year, the 5th year, and then there will be quite a significant revision. This is our mission and our strategy. We haven't changed that at all. We will be reviewing, as we do on an annual basis, our big signals to make sure that they're fit for purpose. I hope you've all had copies of our slides. I'm happy to take any questions, but I'm going to skip through the stuff that's all on our website. This year's round of annual planning will finish in 2023. And what I'm going to present today is the quality account that will be published in May, which looked back to last year, 2021/22, and includes quality and safety priorities for next year, 22/23. Just a little bit about the context of this round. It has been difficult. The way the quality accounts have been published has changed throughout COVID because of the pandemic. And COVID has had a significant impact, principally because we have had to redeploy a number of staff, including staff who would be in quality improvement roles, into frontline business. That has impacted upon our ability to deliver the priorities from last year. But we do remain committed to improving despite the COVID pandemic and recovering from it. So, just a reminder about the look back. The quality account is highly specified in terms of the words and what is audited within it. There was a change to the recommendations in that we didn't need to have external auditors for last year's accounts, but I think, and the plan is that no indicators are to be tested by external audit again this year. Okay, so process is underway. We'll finish the draft. We've written most of it by the end of April. That will go through a final approval process in Northumbria and then should be with you in draft format by May for comment and feedback about that when you, and you can give us your thoughts. So just reminding you about what we said we would do last year. We wanted to get back on the bike in terms of access standards. I think when this was originally originally intended. We thought that probably 2 waves was enough. I don't want to disappoint anybody, but I am told by colleagues who do work in public health that actually a pandemic usually lasts 3 years, and we're only just into the start of the 3rd year. So there may yet be further disturbance as to what goes on. Fingers crossed anyway. Looking at outpatients, looking at deteriorating patients, and by that we mean, I use the phrase physiological, but that's the observations that are undertaken. We've had a focus on delirium, and delirium is very important in people with acute illness, particularly infections, and those who are vulnerable to delirium will include people who either have a diagnosis of dementia or subsequently go on to get a diagnosis of dementia. Patient group directives, as a fully fledged prescriber, these don't usually affect the way that I work, but a large number of our areas do need to run on nurses who need to deliver medicines, whether that's for treatment of urinary tract infections or communicable diseases in sexual health. And there is a process of patient group directions, and this is around the governance of that. Our child and adolescent mental health services, we don't run any of those in Northumberland, but we do for the North Tyneside area, and working at, on access for that important area. And then, of course, as we always do, particularly at the request of our governors, to have a real focus on patient and staff experience. And that is because of the important link between patient and staff experience and safety and effectiveness. Okay, so there's a bit more red this year than we would have liked. I'll just go forward so I can read it. So what we've got is referral to treatment, diagnostics, cancer, and our emergency department, or the 4-hour targets. And we have failed to meet all of those, the targets that we set ourselves, although I would like to point out that in terms of elective care, which is the refer to treatment target, and for 4-hour waits in ED, we are comfortably the leading provider trust in the country in terms of that performance. So we are ahead of the pack, but we are not where we want to be, and neither are we in terms of cancer. But if you actually look, we were aiming in terms of referral to treatment for 92%, and we achieved 87%. Just this week we've had a little dent in our ambitions due to the current busyness of our ED departments. That has meant we are having to move surgery around, but what we always try to do is move rather than cancel. Our cancer targets, again, not just because of diagnostic weights, but particularly because of the complexity of some of those targets, we haven't managed to achieve our intended performance of meeting that standard. So in terms of management of the acutely unwell patient and deteriorating patients, then actually we have partially met the target, and that has sort of flipped in and out of meeting the target depending on whether we've been able to get the practice development team to work with the teams on the wards. We have shown that where we are able to, and the wards are in a state in terms of the pandemic, so that they're open for our practice development teams. Sometimes we've had to close them to visitors due to, for instance, our respiratory support units and the number of COVID patients that they've had. But where we have been able, where the practice development team has been able to get in, then we have been able to demonstrate an improvement. What we haven't been able to do is to do that as widely as we would have liked, or for as much of the year that we would like. In terms of the supply and administration of medicines, We have now put an electronic audit tool in so that we can now absolutely guarantee that all of the appropriate paperwork is 100% up to date, and we are working very well in removing the need for such a large number of PGDs, although some of them, such as the issuing of ibuprofen and paracetamol, we haven't managed to achieve because of the way those medicines are regulated. It's been a difficult year for child and adolescent mental health services. There's been enormous pressure on those services right the way across the NHS, and our services haven't been spared that. We have been working very, very hard to keep the waits under control, and we are seeing all of the urgent patients within the timeframes required, but some of the routine assessments that we need to make, particularly on children with diagnoses such as ADHD, we're not managing to meet the targets that we set ourselves, and we're trying to continue to work out ways that we can improve that. In terms of outpatients, this was around managing to continue the improvements that we made in terms of access to outpatients via video conferencing at around 30% of all our outpatient, all our appointments, and we have been able to do that. And we have also been able to do that and determine whether this is beneficial for patients. There has been a patient experience arm to this, and what I want to reassure colleagues is that actually this does improve for certain cohorts of younger it is easier for them to go to outpatients virtually where that is appropriate. So that's been something that we have met. And we have been aiming to improve our use of advice and guidance. This is a new service that's been that we've implemented over the last 2 years. It's very popular both with referring colleagues in primary care and in secondary care, and I think it is going to be something that we'll be continuing to work on. We didn't, however, we managed in Q3 to achieve 76.9% against our target of 79%. There is, of course, the final quarter. I don't know the dates, the numbers for that. Delirium, we have appointed and also sought some funding from the NIHR, the National Research Institute, on delirium, and the two aspects of it. Firstly is the recognition of delirium using the 4AT tool, and whilst we didn't achieve our target, we achieved 74%. And we were aiming for 77.5. So we have done made considerable improvements in that new detection mode, and we then also undertake what is known as pinch me, which is to look for reversible causes of delirium. All our patient and staff experience targets are on target, and we continue to develop those, and they remain very important. And actually our staff experience programme has been absolutely vital to staff morale through the COVID campaign. So I'm now going to hand you over to Rachel, who's our new Patient Safety Director, and she's going to tell you about next year.
Thank you. Good afternoon, everyone, and thank you for the opportunity to come and present. It's lovely to meet you all. I've been in Northumbria just over a year now, so still feel slightly new because I've hardly met anyone due to COVID. It's all been via Teams, so it's nice to be here in person. So yeah, as Jeremy said, I'm just going to explain a bit about what we're wanting to deliver in the coming year, and explain a little bit about the thought process behind S&Q priorities going forwards. So my role was a new role to the organisation, and it's allowing us an opportunity to just streamline everything that we're doing within safety and quality and have it under one umbrella. So we've got the launch of a much wider patient safety strategy in Northumbria. We've got a new national patient safety strategy. So all of these things are really aligning and helping us to create a vision of what our S&Q priorities are going forwards, which are essentially just a snapshot of what we're trying to do with safety and quality across the organisation. So you'll be very aware from previous presentations the process that we go through at Northumbria to define our S&Q priorities every year. We work very closely with the business units and we also collaborate with our governors and other stakeholders like yourselves to make sure that we are identifying the right things to drive forwards for improvement. For the coming year, we've identified 6 possible priorities that we want to discuss today. And some of these are really built on previous years. So some of them you'll be familiar from Jeremy's presentation just given. And also some are new and things that we've identified over the last few months working with our business units. But like I said, just to reinforce, these are really just a snapshot of what we're delivering within the organisation, and our business units have got a really, really robust plan for safety and quality that is much wider than what we are able to define in our S&Q priorities in the quality account. So the 6 proposed priorities as are currently in draft are number 1 around ambulance handover. So I don't think anybody can escape the news around the delays in ambulance handover between ambulance services and EDs across the country. We've chosen to put this in because we really think we need to do some quite specific work and highlight that at a very high level and publish that data. What we're striving to do within the first year is to try and eliminate those 60-minute waits or over. They are obviously our priority because of the potential harm that has on patients who are not only in the ambulance, but those who are waiting for ambulances out in community. We have some national targets and national standards around ambulance handover, so we're using those as our performance measures for that going forward over the next year. We also want to concentrate on medication errors. So medication errors happen in lots of areas that we work in, but we want to focus our attention on community this year. I think it's a really good place to start because we've seen like Dr. Payes said earlier in his presentation, many more patients being managed at home, in their own homes, out in the community. And therefore we have seen an increase in medication errors across the board, across the community as well. So we want to do some work really just to identify what our common themes are, what we can do to improve that, and the lessons learned. Not only for our patients, but for our staff as well. You can imagine that actually performing a medication error can be quite psychologically impactful for our staff, particularly if it results in harm to the patient. And we want to be able to support our staff going forwards in terms of making sure that they know that when they make an error, nobody goes to work to make a mistake deliberately. We want to make sure that our staff feel supported in that process and that we learn from those lessons and share those lessons more widely. So we are aiming to use what we're calling Datix hubs. So we've already got a Datix hub set up in one of the primary care networks. Datix is our incident reporting system. And the Datix hub essentially pulls together all of the Datix incidents that have happened within that primary care network. And we are collectively coming together as multidisciplinary teams to review not only the medication errors, all of the Datixes, but there's a real focus on medication errors in community, to pull out that learning, not only for that primary care network, but to share that more widely across the community services. And like I said, aiming to do that because we know that actually our staff have been psychologically impacted with medication errors in the past, and we feel that this might help improve our staff experience and also our patient experience too. So we will look at the number of medication errors, but that's not our primary driver for proposing this as a priority. Number 3 is around the urology cancer pathway. So like Jeremy alluded to, we've had some real difficulties, as have everybody nationally, in meeting our cancer pathway priorities and standards over the last few years, and that's obviously been impacted by COVID primarily. We've also got some national standards around cancer pathways. We want to focus on urology because it's a complex pathway. It crosses multiple stakeholders, so a lot of our patients are seen in Northumbria initially and then need referring onwards to places like Newcastle, who are equally having the same problems as that we are. So the reason why we want to focus on this one is because it's quite complex. We feel that this one, as well as our other cancer pathways, does combine and helps us to meet our cancer standards. But this one is particularly complex, and we want to really highlight this one and how we're doing and promote that. We then want to look at our medical devices, particularly in maternity. So as part of the much wider patient safety strategy, there's a whole separate strategy around medical devices. We've recently employed a medical devices safety officer, and we haven't had one of those for a couple of years now. That post has been vacant. But there is a lot of work to do around medical devices, and one of the areas that we want to start with is rolling out our new digital database called Equip. So all of our medical devices competency and training is currently held on paper. So as part of our digital strategy and transformation, we want to get that all onto Equip, which is our digital database, and we're starting that within maternity. As a trial, we'll do sort of a plan, do, study, act, quality improvement methodology, see how that works, and then hopefully roll that out across the organisation. It's a good place to start because maternity is a really high risk area from a patient safety perspective. So if we can get it right in maternity, we feel like we can get it right across the board. And then finally, our patient experience and staff experience remains on our proposed priorities list. We feel it's really, really important to do that. As Jeremy said, patient and staff experience have such a strong link to patient safety. So we feel it's vital that we keep those on. And we've decided to focus on, from a patient experience point of view, around the exciting changes that we've had with the robotic assisted surgery programme. So looking at that, our surgeons are very excited about that, but we want to make sure that our patients equally get the same excitement and outcome that they had as they would have had without robotic surgery. We also want to look at redesigning our real-time programme, so that's where we go out and speak to patients. There's been a lot of changes nationally, and the expectations have changed, so we want to redesign that programme and roll that out proper in terms of how we did before COVID. And then improving access for DDEF patients. This is something that has come up quite recently and has come up historically as well around our access and our treatment of patients who are deaf. We would need to just make sure that we are improving that care all of the time. And then finally, from a staff experience point of view, we know how much valuable information that we get from our staff survey internally and as part of the national staff survey. We've had some excellent results recently, but we need to make sure that we're continually listening to our staff. So we want to continue with our own internal pulse surveys going forwards, and with the national staff survey, which some of the questions have changed significantly. So to be able to benchmark that going forwards, we should continue that programme. We're going to try and scale up our staff experience programme, so not only internally within Northumbria, but also working with other partners. We're already working with Belfast Trust at the moment and potentially going to offer a commercial offering from our staff experience programme. We know that lots and lots of people contact us externally about how we deliver our staff experience programme, so we know that that is wanted by people outside of Northumbria. We've got an R3P programme, which is essentially a recovery programme. I wanted to say post-COVID, but we're not post-COVID, during COVID, to make sure that we are still identifying how our staff are feeling during that time. Really, really important that we have that recovery and the readjustment and the reintegration, which is what the programme is about. And then something which is really, really topical at the moment, the impact of poverty, cost of living and quality of life. We know that we have a lot of staff who are worried about this currently, and it's really important that we evaluate that and make sure that we're listening and reacting to that in terms of what we can do to help our staff going forwards. and then a specific staff experience programme with our NHFML colleagues. We just haven't had as much engagement from NHFM colleagues previously in our staff surveys, so we're going to launch a bespoke survey for NHFM so that the board from NHFM have a much more in-depth review of how their staff are feeling going forwards. And that, I think, is it from me.
Thank you very much. Thank you, Dr. Rishmir and Rachel. I'm sorry I didn't get another name.
Carter.
Are you happy to take questions?
Yeah.
Yeah. I think Liz, you have one to start.
I do. Thank you very much for that. It was really interesting and probably highlights the challenges that you've had as an organisation over the last couple of years. My question was really about, well, access to services and how that links into the priorities, because clearly there will be certain communities who have been disproportionately affected in terms of access to services by COVID. But there's no mention in your proposed priorities explicitly around inequalities and how they how that links to patients. So I'm just wondering where that fits.
So Liz, as you know, we're very interested in health inequalities, and actually the sister presentation at North Tyneside was from Johnny and the Health Inequalities Board. So we haven't found any particular disparities between our rather crude measures of inequalities across our access, but that doesn't mean to say that there aren't. And we will be continuing to develop measures. As part of the recovery programme, there is now reporting on various measures of health inequalities during the recovery programme. And we'd be happy, and we are working with partners, both in Northumberland and North Tyneside, to try and identify areas where we can influence that recovery programme. But at this point in time, I think our overall approach has been to try and reduce the wait times for absolutely everyone, to get rid of all of the long waits. And so far, I think that has proven to be effective. But so it's not to say that we aren't interested in inequalities and we won't be looking at them, but we just weren't able to identify any specific metrics that we could achieve in order to deal with that, because it's a somewhat complex area. But love to work. Really looking forward to working together with you, as we always try to do, to improve these things. And any tips you can give us would be great.
Thank you. I've got Councillor Hill, and then I've got Derry from Health Watch.
Thank you. Couple of questions, points. If you look at page 12 and 13, the performance for 21-22, I think by any objective standard, that's really poor. I mean, if you were, 7 out of 13 of the targets are missed, and the most important, by far the most important targets, only 3 have been met, which, although important, are the least important ones. I mean, if you were sitting with your boss at work and you missed all these targets, you'd be out the door, or you would be very close to being out the door. Or if you were providing a service to somebody and you were going through it and you said, oh, you've missed this, you've missed that, you'd be extremely lucky to carry on getting that business. Is this typical of other trusts? How does this compare to other trusts? And what are the repercussions? Because it's, you presented this and said, oh, well, this is poor, we missed that. Do we shrug our shoulders? I mean, this is poor. Any patient, anyone reading that would be worried. So what are the repercussions if we just have this next year and just go, oh, well, we've missed more targets, hey ho, never mind, we'll make some more?
But I did try to address that in what I said, because, of course, that depends upon the ambition that you set with those targets and the circumstances that you set them in. So we did set ourselves a target of returning to the national standards. So if you look at the top 4, the national standards for referral to treatment and the national standards for ED performance. So that was our ambition, and no trust has achieved those ambitions in the country. And the reason I can tell you that is because we currently are ranked top within the NHS provider trusts in the country for those two particular targets. And we're in the top quartile for our cancer performance. So it's because of the ambition that we set. So if you were, I would beg of you, if you were reviewing our performance against our targets, is to also include the ambition that we set as we came out of what was the first year of pandemic. So our comparisons are good.
I accept that, so the comparison, so I think it, like a lot of the conversations we had, the concern is regarding the whole National Health Service rather than particular trust, because I don't think if you look at the targets, speaking generally, 92% of patients have been treated within 18 weeks of referral. I don't think in any general standards anyone would say that's like really ambitious. So I accept the problem. So other trusts are even worse. So there's a problem. We're talking about problem wide of the National Health Service, and I think we can't just keep shrugging our shoulders at this national problem that the National Health Service just isn't working effectively. I mean, that's the only conclusion you come from that, even though you can defend yourself saying, well, everyone else has missed that target as well.
I definitely would not wish to disagree with you.
Right.
I definitely would agree that we can be more ambitious as an NHS. I would definitely agree that we are not satisfied with our current performance. However, there are currently rules in place around that are changing perhaps over the next few weeks, that does impact upon our throughput. For instance, in our elective surgical programme, if you test patients for COVID during a pandemic and there are a lot of positive results and you cancel people as a result of that, it will affect your performance because you lose capacity to treat people, because on the day or near the day of surgery, you get a large number of late cancellations. We are ambitious to change that in the safest way possible, but all of those things are affect our ability to undertake diagnostics. So we are not operating in an ideal environment, and we are committed to trying to change that for the better. But I'm sort of agreeing with you. Well, in fact, I am agreeing with you, is that we can do better, and we are keen to try and help show the way nationally that this is possible.
Thank you for your candid response. Chair, I've got another question, but I'm happy for you to go to others and come back to me as you...
Is that okay with you?
Yeah, that's
We'll
fine.
come back to you. Derry and then Councillor Bowman.
Thank you very much. Derry Health Watch, for those of you who may not have met me before. I think my question is really very much around what Liz mentioned earlier, which was around the inclusion and focus, maybe around inequality, health inequalities. I think, obviously, in this year, this current year, there's a mention, and you've got a couple of measures in there. You've got a couple of priorities in there. You've sort of got one in this one, but it would be nice to see something more fulsome and more addressing some of those issues more widely. I mean, one of the things that we're quite concerned about at the moment is the accessible information standard and how accessible information is about health services to people, especially those with protected characteristics. So I think if there was some way of expanding what you've set your priority there around the deaf and deafened community, that would be really, I think, really a positive thing. So I think you've learnt a lot, obviously, from this year. So how do we broaden that out? And I think that links back also, because one group of people that we're very aware of, or one issue that we're beginning to be very aware of, is the impact of people waiting for services. So the impact that has on their mental health, and obviously as a wider determinant of
of health, that's going to be really important. So I think any work that can be done to give a focus to bringing that in. Obviously, yes, I know it would require you working with other services in Northumberland around health services.
So thank you. You know that you know we are very committed, and we have that is one of the reasons we have chosen to work particularly on the DDEF. That is something that we are able to have been able to identify and is specific and measurable. And one of the problems that we have on an annual basis is that 12 months is a very short period of time to make any changes. And my previous exchange will show that if you choose something that you can't measure or you don't understand a measure, you don't have a baseline, it can be very difficult to commit to a change. But I'd be more than happy to work with you about perhaps widening or being more specific around what we'll be doing around those access targets. But the main problem with that as an area is that it isn't actually that easy to measure, and it isn't actually that easy to demonstrate, because if you just measure whatever the protected characteristic is, but if you just measure the percentage of that in terms of access, you just get means, and it doesn't necessarily impact upon the experience of those individuals. So it isn't a straightforward thing to ask and measure, but we are definitely working on accessibility and health inequalities.
I think the engagement is the key, because I think you can start to get some of those metrics if you engage with people.
Yeah, Derry, it might be worth having a chat with Jen. So there's a clear action plan around accessible information standards and the implementation of that. We're even redoing our website and things like that to make sure it has the gold standard in that sense too. And also, as Jeremy says, our DDEF awareness work is actually seen as exemplars in the system. We still have loads to do, and there's no doubt about it, but it's probably worth you catching up with Jen so at least she can share with you where we are now.
Can I just add to that? Sorry. So as part of what we're setting out to do in terms of the S&Q priorities, so in my plan going forwards this year, I'll be working on the proposed priorities once they're agreed. But I'm also thinking about the following year and building up some of what you've discussed. So it was very interesting sitting listening last week at North Tyneside sister presentation around all of the work that is going on around health inequalities. And in my head, I was thinking, how can we pin something down to get that into next year? So there's lots of things that are already on my agenda that are really, really big projects that are going to take probably up to 5 years to make any sort of significant, sustainable improvement. So actually, let's build some of those into future S&Q priorities going forward. So, but I take your point, and it's really valid. Thank you.
Thank you. Councillor Bowman and then Councillor Dodd.
Thank you, Chair. That was incredible, actually, because that's touching on the subject that I wanted to speak about. I am deaf, and I do go to hospital. I go to doctors, and if I have to take out my hearing aids, the means of communication is lip reading. I can actually lip read. I'm pretty good on the train. I can listen into a conversation at the other end of the carriage, so watch out. But I did have an incident when I was a young man. I went to a waiting room to see about my hearing, and I'm still waiting today to be seen. So 4:30, everybody's packing up, going to work. So it is a big issue within our health service, not as extreme as that, obviously, today, but obviously if the person that's dealing with you is not deaf, there is a lack of understanding of communication. It also happens to be a benefit because of a miscommunication I had with my doctor. I was carted off to hospital within a half an hour. I was seen to for treatment, and it saved my life. So my deafness has impacted on my life. So today I'm sitting here because of it. I would have been dead. I would have been dead within 2 weeks had it not been for this misunderstanding. What I'm trying to say is it is a vital part of communicating with a patient. In my case, it's been a benefit, but I'm sure to a lot of patients it is a stress and it is a concern. I know that you do try, and I'm really excited about the 6 categories that you've identified here. If there's any other categories you think of, can you just please add them? Because it is important that the NHS does recover from COVID, although we always have to deal with COVID in some sense. And, you know, at the end of the day, it is a means of improving people's lives and saving lives. And obviously, as we alluded to earlier with the Rothbury Hospital, it is, when it comes to palliative care, it is important as well. But thank you for everything you do.
Thank you for your time.
Thank you, Councillor Bowman. Councillor Dodd and then Councillor Hunter.
Yeah, I was listening to the radio. I can't remember if it was Radio Newcastle or Radio 2 on the way in here, and it was about performance, and it was specifically about cancer treatment or getting there, and how the figures are all askew now, and we're well behind where we should be. And the point I want to try and make is, it's always a struggle to get an appointment, and they were saying this on the radio, that the first rung of treatment is an appointment with your GP. And if that is difficult to get, and still difficult to get now, you know, and other sort of first step treatments, that is the difficulty that I think a lot of people, or the frustration have of people that just can't get there. You know, it's like a 3-week wait. I don't know what your view is on that.
Yeah, so we do run some primary care services through MPC. They are a separate organisation, so they don't take part in the same quality account process. But they are dealing with access targets, and they are setting themselves some challenging targets in terms of their responsiveness, particularly to telephone consultations. I think the NHS does need to address this, but one of the ways that it will do this is by actually broadening what it accepts as access, and then what it subsequently does. So advice and guidance might not seem particularly relevant to this conversation, but actually, if you have to have a face-to-face appointment for all of the questions to be answered by a GP, which is essentially, I think, the system of about 2.5-3 years ago, then you waste a lot of those face-to-face encounters, and they don't all add the same value as they do as if you were on a cancer pathway. So by changing the way that we access healthcare, I think that is part of the solution to the problem. But we are all working to improve access in healthcare. I haven't encountered any primary care providers that aren't concerned with access to their own targets. So that is all something that we collectively need to work together. And there's lots of contributions that we can all make by visiting the pharmacists for various minor ailments, so that we do leave capacity and make the best value use of the capacity that we have. Because most of the interactions, and there will be thousands of interactions, there will be hundreds of interactions in our ED department, but there will be thousands of interactions in primary care, whether they're telephone calls, sometimes video, or sometimes face-to-face. And it is really, really important that we try to make the best use of all of those facilities, because we do have actually quite a lot of capacity within the NHS, but we need to use that wisely.
Jeremy, just to add to that, I think there was a discussion at a previous OSC some months ago around GP access, and I think it's either the OSC or it was the Health and Wellbeing Board, and I think it was the OSC, yeah, and I think there was a commitment to bring something back around accessing GP services. So Rachel, I don't know. Yeah.
Yeah, sorry, yeah, just to come in on that, I think if you remember when Dr Graham Sires and Dr Robin Hudson talked about access, we talked about a piece of engagement that we were doing, which we've just got the sort of final report in, so we'd be really happy to bring that back, and it's quite extensive research. Healthwatch has been involved to sort of engage with people about what is access, what's important to them, is it face-to-face, how do they find the virtual appointments that obviously came available in COVID. So we absolutely have got lots to do in that area. It is very mentioned a lot nationally, but we've done that piece of work, and there will be lots to follow as we work with people and with practices to sort of improve our access really, and patients' understanding of how to access and what's the best way forward. So happy to bring that back when we've finished that.
Thank you. The report of that meeting is actually in the minutes that came out that we just approved. I can't remember now whether it was the 1st of March or the 15th of February, but we have just approved those minutes. I'm going to take Councillor Hunter next, and then Councillor Ferguson.
Thank you, Chair. A couple of questions just on the performance targets that we've not met. I appreciate they have to be challenging. It's not worth having a target if it's not going to be challenging. But is it maybe that the targets are set too high for the challenge, or is it just that maybe COVID, if COVID hadn't been there, maybe you would have been closer, which I presume it would have been. And the other one is on the ambulance handover. It's something that's been a problem for many years, many years, and it would be great to eliminate at least the 60-minute wait, because a lot of the ambulances, they're travelling a fair distance. So yes, I know that they do stack up coming from the north area, but again, if you end up with 2 or 3 ambulances having to go from the north area, then you're sort of starting to struggle. So it's a case of hopefully that's not too ambitious, the one that can at least get rid of that one, and the 30 minutes would be even better bonus. Thank you.
Can I take those in reverse order? So the ambulance targets aren't entirely in our gift. I wish they were. Some of them are a little bit hard-coded into how our systems work, because other hospitals don't have that sort of single point of access that we do have. But it has been a thorn in our side, and there is a strong commitment to us to try and to make a proper dent into that. In terms of the access targets, I think I would probably more sympathise with the previous questioner that 4 hours isn't or 18 weeks for elective care isn't that unreasonable. These are targets that we have achieved on a consistent basis within living memory, maybe not every month of the year, but we have achieved that. COVID has not helped. But with or without COVID, and it looks like with COVID, we need to achieve them again, is my view.
Thank you. Where am I? Councillor Ferguson, and then Councillor Hardy.
Thank you, Chair. Apologies, because this possibly isn't really a question, so I hope you do forgive me. But I just wanted to say, I think anyone who, it's been quite well documented over the last couple of years, the issues that the NHS has faced in front of COVID. I think anyone who works in the NHS or knows people who has family or friends working in the NHS will have understood the impact that COVID has had on staff. So I think whilst the objectives from last year, it looks like there's a lot of red there, I think the fact that the targets around staff experience and patient experience have been met is an absolute credit to yourselves and to everyone else working within the NHS. Looking forward to the priorities for the next year, as someone who's got quite an interest in medication safety, it was really good to hear you talking about the link between patient experience and staff experience, but also about supporting staff through medication errors, because I think that's really, really important, especially around staff retention and helping kind of learn from that. And as someone who's quite interested in the whole idea of the just culture within the NHS, it's very good to see that that's forming part and that we're moving forward with that as the trust. And I think just thank you very much for the presentation and for the work that you do and that you've been doing through COVID.
Thank you for your comments. Maybe we should put this. Yeah, we should put the staff and patient experience first and at the top of the list, because it is the thing from which all good comes.
Thank you, Councillor Ferguson. Councillor Hardy, I think, and then I'm just going to go back to Councillor Hill. And if we're all very quick, I think Councillor Bowman had his hand up again, but we've got quite a lot still on the agenda, so we do need to move a little quicker.
Thank you. Thanks for your presentation. 2 questions. One is, I tested your system. Being a part of the overview and scrutiny, I decided that during Storm Arwen, I would have an accident and see if you could get me down to hospital and put me back together again, which you did, despite of COVID. And I had a turnaround figure of 2 days, and I'm still sitting here uncomfortable at the damage that I caused myself. So I would like to say thank you, and I would want to ask, do you see that as a positive reflection on your targets, in the fact that I was taken in, transferred from ambulance within 2 hours, triaged through and into an emergency ward within a further half hour. People were doing things to me that I didn't understand, but I'm here to tell the tale. So is that a positive?
That is a positive, and we do. I think it is really important to reflect, and I'm grateful for your comments about the good work that people do, because we can learn from the things that we do right as well as the things that we do wrong. And there are plenty of people, even though we only achieved 92% inside 4 hours. That means there are a lot of people who were inside 4 hours and actually a lot less. So, but that applies to everything that we do, and we try to learn from what we do well and what we don't do as well.
And my second question relates to an article in the Financial Times that points out that Northumberland NHS is actually leading the way forward in the reduction of waiting times through the £36 billion over 3-year injection into the health and social care service through the levy. Do you see that as an achievable ambition? Obviously, the Financial Times thinks it's achievable, otherwise they wouldn't do the argument. Do you see that as an achievable ambition?
I've worked for the NHS all of my life, and the NHS has to succeed in this. I'm very pleased that the government has put its money where its mouth is, and it would be my ambition that we would continue to respond to that investment and to sort some of the issues out. But that will require a fair degree of performance management. But we also have Sir Jim helping everyone else in the country to do the same. Fingers crossed.
Councillor Hill and then Councillor Bowman, and I think we'll make that the last question on this presentation. Thank you.
I noticed there's been quite a lot on the NHS Northumbria Healthcare Facebook page and in this presentation talking about staff being really positive. I've been in companies where they've done these staff surveys. I remember my boss saying to me, right, everyone, can you do your staff surveys this afternoon? And I said, oh, well, I've already done mine. I just did it at my lunch break, whatever. And they said, what did you answer? And I said, oh, it was goods and very good, 1 excellent, I think. And they were, what do you mean? It wasn't all excellent. Right, everyone's got to put excellent now. Then she gets on to her boss and says, Tom or whatever his name is, I can't remember now, says everyone can go to the pub early this afternoon, you know. So you can see subtly the way that these things can be done. So the question is, how robust are these staff surveys? Is there not little bits of subtle pressure, people honestly, anonymously saying, not that this is, it's obviously great for the staff and you want a company that staff are happy, of course. It's not the biggest concern in the whole health sphere and what the public are concerned about, but I know how these things work. Is these surveys done in a robust way, or is it a bit like the kind of thing I've explained?
Very much so. And I work in the place. I work in this place. I work in intensive care, and it fits with what we found. And we have seen the good and the bad. When it was bad in COVID and Boris wasn't getting his messages quite right, we could tell. We could tell that upset the staff. So we could tell those dips, and yes, we do bribe our staff. Yes, we did give them, Claire organises a number of gifts, and it's not a bribe to fill in the surveys, it's to show them with a small gesture that we care.
So I can definitely confirm we can't go to the pub, Georgina, whilst we may want to. But also, in all, it's really important to remember there are a few different surveys. So there is the National Staff Survey, which we just last week were announced as the best in the country. We do our own independent pulse surveys on a regular basis that are then independently audited too. So all of it is, these are independent representative samples of our staff, but actually, you know, they're not really samples. Some, you know, best part of half of the workforce are completing the staff survey. That is significant when it comes to the numbers of the workforce that we've got. In our staff experience programme, in our reward and recognition for the work that our staff do, they are tokens. It's not like we can give big things away, but they are tokens of appreciation that go down really, really well with our staff.
Thank you. Councillor Bowman.
Thank you, Chair. We live in a world where we have COVID. We're going to have to live with this in society for, say, forever. You've got 6 priorities that you're looking into to improve your services. Can I ask you, how is it that COVID is going to impact on the National Health Service for the future? Will it be short term? Will it be long term? How will it damage the NHS? And how can you come up with a solution that...
I'll ask Mystic Meg. So the Russian flu pandemic of, I think, about 1890 was a coronavirus. Probably the first coronavirus. And that did actually turn into one of the causes of the common cold. So the virus isn't going to go away, but it already has changed and is becoming more recognisable in something that we understand, something that we can deal with. But just as we have other infectious diseases, it is always going to be there. It is always something that we're going to deal with. We don't have more of an ability to influence it except through vaccination programs, looking after the clinically extremely vulnerable. But we'll continue to make the right choices. I think the choices that we need to make are balancing the risk of coronavirus as it is now against the other risks within the system, because heart attacks, deafness, or lots of other issues have not gone away, and we mustn't lose sight of everything that we need to do, of which coronavirus will be a part. So for me, it's about putting it in its place, dealing with it, managing it as best we can, but as we do with either seasonal flu, ordinary bacterial pneumonia, septicemia, cancer, Uncle Tom Cobley and all.
Thank you. Well, thank you very much. I think we've had a good discussion on your accounts, on your quality accounts, so thank you very much. We're going to move on, but I will, as before, give the NHS staff a chance to get back to your busy jobs.
Thank you very much.
Thank you. I'm going to once again make some changes to the agenda as time's running on. We're going to take the review of the addiction services next, and I think trying to look, see, is it John Little? Are you going to take this? Yeah, thank you. Do you want to move up at all? Oh, you want that as well?
Okay, so hi everyone. So I'm John Liddell. I work in the public health team in the council. I'm joined by a couple of colleagues from our treatment service today as well. So we've got Chrissy Currick and Sam Ruth along today. So we're going to do a little bit of a. Is that just gone off there? All right. Okay. Right. I'll just ramble on a little bit while he's doing that. So it's we're going to do a little bit of a sort of a double act today. So we circulated the report as part of the papers, which gives some detail about two kind of important developments that have taken place within the drug and alcohol treatment sector, mainly the drug treatment sector, to be fair. So that was the independent review of drugs that was conducted by Professor Dame Carol Black, and also the new drug strategy, which the review kind of heavily influenced. So really it was just to tell you a little bit about those today. I'm not going to go through the report line by line because you've had access to that, and I'm sure you've had a chance to read it. So it's really the presentations, just to give you a little bit of context about what that review found and what our system looks like in kind of response to those findings. And the reason we've got Chrissy and Sam here today is to really be able to give you that kind of expert viewpoint of what the service actually delivers and what their experiences are of this sector. So, let's see if this works. Jump on. Okay, right. So just to go back over the two kind of reports that I mentioned. So, as I said, the first one is an independent review, which was commissioned by the government in I think 2019, and was conducted by Professor Dame Carol Black and a team of experts, of course. So the findings of that report were that there's a really clear link between addiction and violent crime and deprivation. Everywhere you find addiction, you find violent crime, increasing levels of violent crime, often organised violent crime. I'm sure you've heard of things like county lines. Deprivation tends to go hand in hand with drug use, alcohol use, and ultimately addiction as well. DRD, that's drug-related deaths, so they're at an all-time high at the moment. They've been steadily creeping up for about probably the past 10 years in this country, and currently at the highest point they've ever been. The findings found that there was a reduced treatment resource, that treatment services had kind of lost a bit of capacity in recent years, and then in some areas there'd been disinvestment in those services. So the response that we had to addiction had kind of shrunk. Recommendations of that report, there were a lot of them. There was about 35 recommendations, I think. So in summary, the recommendations said that there needed to be some form of additional protected funding from the government to local authorities to help kind of increase the capacity and quality of services. We needed to focus on the wider determinants, so not just think about addiction, but obviously think about where that addiction actually came from in the first place and what we can do to address it. And we need access to things like employment and housing. It's incredibly, even if you go through a treatment system successfully, if you conquer your addiction, it's incredibly difficult to maintain that abstinence if you haven't got anything to fill your life with, if you haven't got somewhere decent to live, something to do with your time like a job. So those findings and recommendations were used to develop the new drug strategy. Now, obviously, the drug strategy isn't just about treatment, it's about prevention, there's a very strong criminal justice element in there as well, but our little bit of the forest just around treatment. The good news in that was that there was this 3-year funding package announced, so that the figures are in the report. So all local authorities are going to be given this enhanced protected funding to use to kind of develop their treatment systems. It's for community treatment, it's also for residential rehab, and also inpatient detox. So there's a few requirements in there. We need to maintain existing funding, existing investment. We have to kind of prepare ourselves for some increased national scrutiny that's going to come alongside this funding. Obviously, the government wants to know what it is we're going to be delivering and how we're delivering it. And there's going to be a focus on those things there. So unmet need, increasing numbers in treatment, addressing drug-related deaths and so forth. So a little bit of what I'm going to get onto will kind of tell you about what kind of, I suppose, what sort of shape our system's in to be able to respond to that. So first off, just another little bit of context is, I'm sure no one's going to be kind of surprised to hear that addiction's bad for you, very bad for you. But it's not just bad for you, it's bad for everyone, all of us. It costs an enormous amount of money. So DH figures estimate nearly 11 billion is the annual cost of illicit drug use in the UK. The damages to the individual are extreme, to be honest, but the issue for their families, their community, society at large, it affects, as I say, it affects everyone. So those costs are to do with the crime that comes as a result, the extra policing we have to put in place, the health costs, family breakdown, kids not in schools, people being unable to work and so on. And Department of Health estimate that when we spend £1 on treatment, we generally save about £2.50 in against the kind of cost above. So the little picture there, the next one is, as I say, just about some of the harms that drug cause. I don't suppose anyone's in any doubt about this, but we see a lot of deaths as a result of drug addiction. It's mainly around an older group, 45 to 49-year-olds are the people most likely to die of a drug-related death. Often people who use substances harmfully have years, decades in some cases, of incredibly poor health. So when if they do eventually die, it's often as a result of a huge range of complicated issues that have come to a head. Ironically, they're often people who don't tend to access services. So they're not generally the people who don't tend to go to their GP. That often, for all kinds of reasons, can feel excluded from mainstream health services, which is why we need specialist services. Treatment, specialist treatment prevents drug-related deaths. It saves people's lives without a doubt. It also prevents the spread of bloodborne viruses. It does a huge amount of things, but just purely on the health side. So there's less things like hepatitis, HIV in our communities because the treatment services can help address that. So right, that's a little bit complicated to see, and some of you are quite far away from it, I'm conscious. But one of the recommendations is, which will come down with the new funding, is that we basically get more people into treatment. So we've got quite a lot of people in treatment, we've got over 2,000 in at the moment, and that's been on a kind of a steady increase for most substances. That's the little colourful graph at the top is broken up by substance. So you can see from around about 2018-19, everything's going up. Okay, there's more people wanting to get into treatment now. There's a bit of a two-hander there, because on one side we can think more people are using drugs and alcohol problematically, so something's gone drastically wrong. What we're actually measuring here is how many people are getting into treatment. So of the people in the community who have got a problem, more of them are getting into our service. More of our residents are getting into our services and being helped along the way. So the target that's going to come down about getting more people in, I think we're in a pretty good place to address that, to be honest. We're going to increase the capacity within the service anyway. So we're in a pretty good place to get more in. Right, that one again. So this is unmet need. So again, I'm not going to expect you can see that from where some of you are sat, but what this is measuring is of everyone who would benefit from getting into treatment, how many of them are actually in. So obviously you want the figure in to be higher than the figure that aren't in, because the ones that aren't in are the people that are causing more issues for themselves and their communities within Northumberland. So we had a kind of a high point of success around 2015-16, where only 33% of people who would benefit from treatment weren't in. The vast bulk of people were in, and that went up a little bit in 2016-17. But we've been chipping away at that. We've kind of got back to where we were. So that figure, I understand you might look at it and think, well, there's still 38% of people in the community who aren't accessing treatment. drug and alcohol addiction is incredibly complex. There's people who will never access treatment, never. So we would never have 100%. Actually, that figure there is very comparable to the national average, a bit better actually. It's an estimate, of course, and it kind of goes up to it goes up to 2019-20. Now, what we kind of have to prepare ourselves for is that we know that there's been increased levels of problematic use during COVID. Need will almost certainly have increased within our community. So we have to kind of, as I say, prepare ourselves for that, for potentially an influx of people coming into service. But the new funding we're going to be given will go some way to helping us do that. So last one from me, I'm going to hand over to colleagues in the service. So this is deaths. So it's categorised by the North East average, our own figure, and also the national average. So where the blue line in the middle there. So ultimately, the story of the graph at the top is where below the regional average, there's areas in the North East fare far worse than us. We've actually got the lowest rate of drug-related deaths in the North East. We are above the national average, though. So, as I mentioned earlier, drug-related death is absolutely intrinsically linked to all kinds of issues, but health and social inequality are the big one. Anywhere you look that has high levels of that, high levels of deprivation, you'll also see high levels of drug-related deaths. Generation X is a term that's used nationally in some publications, and it describes the group I mentioned earlier, that kind of 45 to 49-year-old age group, people who were born in the 70s, essentially. Often people who began using heroin, opiates problematically, possibly in the kind of 90s. They've maintained an addiction, quite a dangerous addiction, and a lifestyle that goes with it, of course, but in some cases 2 decades. By the time, in some cases, they present the treatment, as I mentioned earlier, their health can be quite poor. Actually, they could have some pretty chronic health issues, and the service, as I'm sure the guys will mention, doesn't just treat addiction. It can end up treating a whole host of health conditions. So, and that's kind of what I've mentioned at the bottom there, actually, is that we can, as I mentioned earlier, we can prevent drug-related death, but the issue we've got is we have this cohort of ageing drug users, people whose health is terrible sometimes. And although they access treatment, a lot of the conditions they have are long-term. They've done long-lasting damage to themselves, unfortunately. Right. I'm going to hand over to colleagues. Do you want the beep or do you want me to do it for you? I'm going to give it to you. Don't want the responsibility.
Hello, my name's Chrissy Correc. I'm the Clinical Manager for Northumberland Recovery Partnership. Apologies to those people who can see my back. So myself, I'm here with my colleague Sam Ruth, who I'll let you introduce yourself, Sam.
Hi, I'm Sam. I'm the Service Manager for the Changing Lives element of Northumberland Recovery Partnership.
So we wanted to just come along and give a little bit of an overview of what the service delivers and some of the challenges that we've faced because of COVID and the things that we've done to address that. So for those people who don't know about how our service works, we are a partnership organisation, and that includes CNTW, who I'm employed by, Changing Lives and Turning Point. And unfortunately, our Turning Point colleague couldn't make it today because of other commitments. We are here to help service users get well and stay well. I haven't done the you be in charge of that. We're here to help people get well and stay well and begin that journey to the recovery from addiction and substance misuse. We don't ask people to come in and identify complete abstinence. We want them to support them in whatever way they feel recovery is achievable for them. For some of them that is abstinence, and for some of them that is around simply reducing the harm for those people. To do that, we'll have a harm reduction service. Those of you who know NRP may know about our needle exchange, where we deliver clean works for our service users to reduce the risk of spread of bloodborne virus, We talk to service users about safer injecting practices. We assess any injecting wounds and support people with that. We have dedicated recovery coordinators in the service, and they are there to work with service users to navigate them through their recovery journey as such, and support them to make whatever small, large change they want to do in their life. We have our clinical team who work with service users who are using opiates and require opiate substitute prescribing, and that includes both methadone and buprenorphine, and more recently injectable buprenorphine, which we're starting to trial with service users. We have very strong links with our community, which Sam will be able to explain a little bit more about.
So we facilitate groups from a couple of bases throughout Northumberland. So we have bases in Blythe, Ashington, Berwick and Hexham. But a big part of supporting people with their recovery is getting back into the community. So we have made amazing links with community organisations such as local churches, community centres, and what we will do is we will see how we could support with the local community centres. So if the community centre, say in Blythe, has identified they have a couple of people coming in who need relapse prevention, we can offer some support from one of the group facilitators from within the partnership, who will go along and facilitate a group, but it will be also open to some of the people who are accessing NRP. So we're trying to make links back and getting people back into engaging with the community. So we've got lots of different groups in the community, and also run from bases as well.
Yeah, we also have our abstinence-based programmes. So we've got our Oak Trees non-residential rehab, which is situated in Blythe, and we have pop-up rehabs within our more rural areas to make it accessible to all of our service users.
And the Oak Trees programme is a 12-step, 12-week day rehab. So what that encourages is people to come into treatment between 9 and 5, but they're also going back to their own community, but they're able to sort of get the support that they need for integrating back into the community, rather than going away into a private rehab where they're sort of leaving the support networks in the community. We encourage the day community, the day rehab, to build up them links.
I think with that said, we can still facilitate people going into a private residential rehab if that's the right treatment option for them. I think we need to be flexible in our approach with our service users, because it's not a one-size-fits-all. We need to be led by the service users to what helps them and supports them the best.
It's a case by case, isn't it?
Yeah. So, can you... Yeah, it's on. No, the next one. No. I think it's probably important to highlight the impact that COVID has had on the service. We very quickly found ourselves in a position where we were being asked by community pharmacies to support them to reduce footfall into pharmacies. We had to work very quickly to change the way in which our service users on opiate substitute prescribing were collecting their prescription from pharmacy whilst keeping them safe. This also included at times having to deliver people's medication to their doors, and that was in order to keep people on a script and reduce the risk for them, because those people who were having to isolate had no means of getting that medication themselves. We very quickly recognised that we have a cohort of service users who have an undisclosed income, and that potentially they lost that undisclosed income. So there was fuel poverty, there was a need for food parcels, we provided people with mobile phones. We had a huge amount of service users who were absolutely terrified at the thought of coming into treatment services because of all of the media around COVID, and there was a real resistance for some of them. So we had to agree working in a very different way and using the hybrid approach. So some people would access via a Teams platform, or we would contact them on the mobile that we'd provided them with. We also very quickly acknowledged that some of our service users became incredibly isolated throughout this period because the addictions service and the offer that we give is for some people the only contact they have. So we did regular door knocks to check that people were all right, taking food parcels out of them and making sure that we were meeting all of their needs. We provided vaccinations for our service users. So we did a bit of work to identify those service users who would not access their GP or any other means of getting the vaccination, and have been able to give those service users the vaccination. We provided people with welfare packs to stop them from feeling so isolated and reduce their boredom, etc. We did a lot. We had to really change the way in which we worked, but make sure it was delivered as safely as possible. We do feel that we've learned a lot from some of those changes, and some of those changes that we've made would like to sustain, because what we recognised is that Northumberland is a huge, vast area, and historically we've really pushed for service users to come to us and maybe not acknowledge the huge amount of travel that some people had to undertake to get to us, and potential working arrangements that they might have to organise, childcare. And what we've seen is an increase in engagement with the service, because there are more options to access the service.
And I think also running a primary care in the rehab and recovery groups, when we went into lockdown, what we were going to do, you know, people were wanting to come into treatment. So again, like Chrissy said, within a couple of hours, we were able to deliver treatment and recovery groups via Microsoft Teams, which enabled people who were in the rural areas to also access.
Yeah. Do you want to? So, yeah. So we feel we've done a lot of good work. We have been very fortunate to be able to support our service users to access training, employment, gyms, to be able to start addressing their fitness and in turn addressing their physical health. We have strengthened our physical health monitoring and have a dedicated physical health nurse who is starting to look at the what John was making reference to. Some of these people have had underlying physical health problems for a very long time, but there's a reluctance for them to access their GPs or other areas that they could get support with. So our dedicated physical health nurse is running drop-in clinics. She's going out to people's homes. She's, you know, supporting them to be referred into appropriate services. We have very good relationships with our Hepatitis C Trust, and they deliver an outreach model to our services where they deliver treatment. So rather than asking our service users to go to them, they come to us, and we'll have a very good success rate of people successfully completing treatment. We've strengthened our pathways, so we have very dedicated pathways for those who use alcohol, those who use opiates, those who may need an alcohol detox, whether that be an elective inpatient detox or a community home detox. We have now a dedicated bed in a ward called Gibbside in Newcastle, which we can put our service users forward for an elective detox. We also access more specialist units such as Castle Craig for those detox that are more complex and will require more intervention. We've developed a resettlement pathway because we've acknowledged that those people who are being released from prison often are going very quickly back into prison. So we've enhanced the offer to them, and we see them regularly. We have their physical health monitored, we have their mental health monitored, we have them supported by our housing worker, we get our peer support worker involved to have that lived experience and evidence of recovery. So that, and the hope is that with that improved service, that improved resettlement pathway, we'll see people supported to stay in the community. I think that's it. Do you want to?
Yes.
The challenges that we're facing as a service, John has already made reference to an unprecedented national increase in drug and alcohol deaths. We are seeing, whilst we see that 44 to 49-year-old population, we're also seeing a younger population. We're seeing younger people come in having used alcohol with deteriorated physical health at quite a young age. There has been, as John's already referenced to, a huge increase in demand for the service. There's not going to be an issue about that increase that we need to achieve, because we're seeing it anyway. We have had the things like county lines, where we've had incredibly vulnerable service users who need additional support from us, and again are very unwilling to engage with police, etc. We have had seen national difficulties in recruitment of staff, and that's just not just within nursing, that's within all parts of the partnership. So we're having to really think about how we recruit people and consider different disciplines that we might be able to bring in. And we are seeing an increase in caseload sizes, which means that our workers are working with a huge number of people to try and maintain the safety of those that they're working with. Our visions, we wanted to continue the work that we're doing. We want to continue to support people to reduce risk using psychological interventions, using opiate substitute prescribing. We want to hear what our service users want, and we are starting to have focus groups again to think about how we can inform future changes in the service. We want to learn, absolutely want to learn from our drug-related deaths or significant incidents, and we're very fortunate that CNTW have a very robust process whereby there is a very robust review of any incident and learning opportunities that we share amongst the staff and other addiction services. We want to flood the streets with naloxone, so we now are fortunate enough to have naloxone and nasal naloxone, and there's a real push for us to ensure that we're revisiting that with every review that we have with service users. We want to continue to remove the stigma in relation to substance misuse, and I think the work that we're doing, that community asset building, is going to support us to do that. We want to ensure that recovery is visible, so it's very important for us to have people who work within the service who've been in treatment previously, so that our service users can see that there is opportunity there. We want to continue to work closely with our primary care colleagues and other services that our service users need to support. So we have interface meetings with crisis teams, psych liaison teams, community mental health teams. That interface meeting is ever growing, and we're inviting more people to it all of the time. And that's to ensure that our service users have the right person working with them at the right time. Want to say anything else? I think that's it. If anybody's got any questions.
Thank you. It's really interesting to hear about the work you're doing, particularly in the community, and the challenges you face. So I'm going to take questions. John, as well, there's the questions on the report and the Professor Dame Carol Black's report as well in the progress. Councillor Bowman and Councillor Nisbet. Yeah, take Councillor Bowman first.
Thank you, Chair. Wow, that's amazing, isn't it? Every day in my community I see people who suffer, and I mean suffer. And like our colleague here, he identified some of the issues, underlying issues, poverty being one of them, housing being the second, lack of opportunity as well. That's down to education and employment. It's sad, isn't it, that we live in the fifth richest nation in the world and some members of our community haven't got access to that wealth. And it's sad, isn't it, that they choose to use drugs or alcohol to mitigate the stress that they feel in their lives. And some of it may be mental health, some of it may be breakdown of families, some of it may be all sorts of underlying problems we'll never understand. But it's great to see a team here who are willing to tackle it face on. The problem I've got is how do these people access the services? Do they go to their doctors? Is it the police that refer them? Or can we set up a community team within the area to do it sensitively to the people, to provide that information, to provide that link so that they can access the recovery program that you've outlined? Can I just come with a final note? About 4 weeks ago, I saved a person's life who was committing suicide by drug overuse. And it's sad, isn't it, that as I sat there with this person who was dying, I'm sorry, I'll just a few tears here because it is quite tragic. Some good came out of it, by the way, but while encouraging this person and trying to enlighten this person that there is a better life, there is a better days ahead. It is difficult, isn't it, when you sit and you see that person's surroundings and their case, as it were, and their predicament. And the good news was that the paramedics came within 12 minutes. They were there and took charge and saved this person's life. She's now on a pathway to full recovery and no drug use. I can't obviously mention the person's name. She doesn't even live in my ward, actually. But the amazing thing is, what I find is encouraging that last phone call she made wasn't for an ambulance. It wasn't for a friend, but it was to her local councillor. Although I am not her local councillor, it was to me that she made that phone call because she knows of me. Now, I would like to see in the future that sort of incident does not happen. And I don't know how many people have taken their lives because of the predicament of being in with alcohol abuse or drug abuse, or both. But I would like to see that done away with. I would like to see a hope and encouragement. I would like to see that in our society, not the society that I see today, not a society where poverty is accepted, not a society where poor housing
Councillor
is
Bowman,
accepted.
I've not stopped you before because I know this is really goes home to you, but this is a scrutiny committee and it's not a political debate, so I am going to move on.
My concern is that the Changing Lives is actually in Blythe, right in the middle of my ward, in the Reef. Now, my concerns are around that area, the constant turning up of the police, the constant problems, they're getting out on the streets. I thought that was a 24/7 care.
So I think it's important to note that the Reef isn't part of our project. That is a Changing Lives project, but it's separate from NRP. However, what we are doing is trying to strengthen our links with the people who work within that housing project. we've delivered training around naloxone and provision of naloxone, and we have invited staff to our MDTs to be able to talk about the challenges that they experience with that group of service users, but they're not necessarily open to our service. And I guess this comes back to your question as well, is our service, you can refer in yourself, your GP can refer, your social worker can refer, but we have to have the permission of the service user to come into treatment. So for those people in that housing project, we understand there is a problem there, and we're doing everything we can to support that housing project, and we'll support the service users within there, but we can't force them to come into our treatment service.
So you're part of the Northumberland recovery team then?
Yes.
Yes, right, okay. I'm getting the wrong end of it. I thought you were from Changing Lives in itself.
But we're a partnership with Changing Lives, Turning Point and CNTW, but Changing Lives have other external projects that we don't have any influence on.
Well, I'd just like to say that I congratulate you on what you're trying to do. I mean, it is a big job, massive job. As I say, I'm from one of the most deprived wards, and I have got a lot of it in the ward, especially around that one area, which is really sad to see how they've come about to be in that position, you know, but I do appreciate what you're doing. I just thought I was going to give you a bit of stick there, if you in the part of the reef. No, I apologise about that, but keep doing the good work you're doing,
Thank you very much.
And I do have to.
Thank you. Councillor Hill.
Thank you. I think my question might be more for Liz, but it's, I don't know if you read recently, counterparts in Scotland, Public Health Scotland, came out with a report that the minimum pricing for alcohol was not causing people to cross the border to buy alcohol. And I think it was one of these reports that you have to take with a large pinch of salt, because Public Health Scotland and the Scottish Government weren't going to come out with anything that was going to undermine their own policy, to be perfectly honest. And we in Berwick, we don't know the scale. I couldn't give a figure, but we know, and I'm sure Councillor Hunter, our Morrisons and other stores are packed with people coming over the border, you know, to get the cheaper alcohol. And it's a lot cheaper, so particularly if you buy it in bulk, and people that are on restaurants and bars and so on, it's cheaper than the wholesalers. And their argument as well was, not only is this a great policy, and pat ourselves on the back with some dodgy methodology and survey samples and so on, but they're saying the North East should follow suit. What is the thinking? Was there anything in Carol Black's review? What is the thinking in terms of reduced pricing of alcohol? Does it actually, what they say, reduce alcohol intake, or does it just mean that, you know, addicts are going to resort to crime or more deprivation? They're not going to give up the habit by the pricing strategy. So it was just, I just wonder, from an English point of view, from this side of the border, is there any survey work or anything that's been done regarding whether the minimum pricing of alcohol has any beneficial impact in terms of reducing consumption?
I'll pass that over to Liz or John.
I'll start and then I'll hand over to the expert. I mean, there is plenty of evidence from international experience, actually, and the evidence from Scotland, that introducing minimum unit pricing has a significant and actually relatively rapid effect on health outcomes. Certainly in terms of you know, admissions for alcohol-related liver disease, the evidence is very, very clear. Not only that, it impacts on those people who drink the most. I'll hand over to John, because he is the expert in this particular area.
Right, I already want to hear the term expert, but here we go. Just going back to one of your initial questions, it wasn't covered in the Dame Carol Black review because that focused specifically on drugs. So it wasn't kind of referenced in that. But I mean, as Liz says, just in terms of minimum unit price, and there's a growing body of evidence around it. When it was first being looked at in the UK, Scotland were initially looking at it, that evidence was mainly from, well, it was all from abroad. So Scotland adopting it's been a really useful kind of case study because it's answered a lot of questions that we had around it. One of them, as Liz said, was, does it reduce harm? It appears to, absolutely. It reduces the amount of alcohol intake across quite a wide demographic of individuals, but certainly the type of, the group we've perhaps talked about today, it impacts on them as well. So people who drink at harmful levels, it does appear to reduce their intake. So in that sense, it appears to be doing what it sets out to do.
Thank you, Chair. Just because the funding that's coming in, are we getting targets set so that to how proven that the funding is working and that, and when would we see a review? Would that be in a year's time as to if it's working or how it's working, what the issues are?
Yeah, it'll be staged basically. So we work really closely with an organisation called OHID, which is a kind of a sub-department of the Department of Health. They're tasked locally with overseeing the rollout of the funding and also the monitoring of the kind of the outcomes that funding achieves. So there's a lot of kind of planning that will have to take place within Liz's team by myself, which should be done in partnership with the service. We'll take on board the indicators that were set nationally. We'll develop a few of our own actually that are relevant to our local needs as well, and we'll monitor that and report to the schedule. It'll be a quarterly reporting arrangement. But you know, we welcome it because we want to demonstrate the success that we're going to achieve. We want that recognised. The initial funding package that we've been given, that everyone's been given, is for 3 years. It would make sense that extensions to that funding will be based on demonstrable success within communities. So we want to do that. We want to be part of that.
Thank you.
Councillor Dodd.
Yeah, one or two councillors have said, oh, I'm in the most deprived, whatever, divisions boards. And I understand that it's visible in those areas, you know, you can see things. But I hear things, because I don't have the pleasure of being able to see I live in the whatever, I've got parts of Darras Hall and other, you know, not well-to-do, but better off areas. And, you know, I hear more and more people hearing about, oh, there's drugs about, or people are pushing drugs. It's probably not as visible because they've got a disposable income rather than having to get money from, let's say, other sources. Is that on the increase? You know, like a more affluent society are into this. Is that any signs of that, or is it just where drug dealers are going?
Can I come in there? I think there's I think there has always been substance misuse in the more affluent areas. I think access to drugs now is much easier for those people because it doesn't necessarily require a drug dealer to come with those drugs. You can access drugs via the internet now, and a number of drugs. This is one of the challenges that we have. I've worked within addiction services for 16 years and I've seen a huge amount of change. So we don't have to have a drug dealer come to us or go to a drug dealer now to access drugs. So I think it's always been there, but I think access is a lot easier now. I don't know if that answers your question, but...
If it's easy to get online, why aren't I mean, they probably are. Why isn't somebody sort of doing them? Surely, so you know, because at the end of the day, someone's either got to post it, deliver it, and then someone's got to pay for it. Normally, presumably, cash.
I wish I could answer that question. I think that my understanding of the internet and dark web and those areas that they're accessible, it's very fluid and it changes very quickly, so it might be shut down 1 minute and then reopened on a different server the next. And I think sadly it's a business to people, so they will find a way of providing that service, and we have service users who, if that is provided to them. So I think the most important thing is to to give that harm reduction advice and minimise risk and make sure people are making informed choices and they know the risks that they're taking if they choose to access those things. And that's what we try very hard to do, is give that advice and information and show people that there are alternatives to the use of substances. And I think we also have to understand people's rationale for the use of drugs, the reasons why. So we try very hard to, well, we see past the substance misuse and we see the story behind it. And we try to work with the person to address those issues in different ways. I don't think we can eliminate it. I think we just support people to be safe within it. I don't know, John, if you want to, sorry.
Could I just come in on that? I mean, I absolutely agree with what Chris has just said. Really good description of how the treatment service can respond to that. I'll just go back to your initial query about drugs, kind of, ordering drugs on the internet and just how easy it is. How it often works is that we're not necessarily talking about, say, heroin or cocaine, what I would generally term as, the big drugs. We're talking about often like synthetic or designer drugs, which are artificially, grown in lab versions of your common or garden heroin and cocaine and so forth. They use chemicals that aren't necessarily illegal in foreign countries. A lot of them aren't illegal in this country. It can be illegal to combine them, but if you combine them in a foreign country, then you haven't actually broke any laws, and you can post them into this country. So an ideal situation in terms of the drug trade is you want it to be illegal at both ends, because then you've got your own criminal justice services working with the foreign countries. If you can't get the foreign countries' engagement because nobody's broke a law, then it becomes incredibly complex. And unfortunately, a lot of drugs do find their way into the country simply via brown paper envelopes.
Right, I'm going to say thank you very much, John and Chrissy and Sam. What Sam is here. Yes. Thank you so much for coming. I think there's been quite a lot of interest in what you've had to say. So thanks very much. And as again, if you're welcome to stay, but if you'd like to leave, you're very welcome. Yeah. And we've just, the next item on the agenda is the COVID update. So it's up to you. Well, that's the committee, actually.
5 minutes. Seems to be right, so.
Yeah. I'm sure you'd be well aware that Councillor Dodd has a meeting at 4 o'clock.
No, I'm just, you might not be aware, but it's in here.
Right.
Okay, so I will try and be pretty brief. So you have got a report in your packs, but obviously the report was written before the tidal wave of guidance came out on Friday, some of which actually only lasted until Monday. So in the week up to the 26th of March, it's estimated that we had about, over 4 million cases of COVID in England alone. So you could be forgiven for asking why we're taking a change of approach at this particular time. But what we do know is that the pandemic is just going to take its own course. So there's probably no right time to do this, and we can expect to operate in a period of turbulence for probably the next 18 months to 2 years. But the good things is that we're heading into spring, where the weather is hopefully going to be better. People are going to be mixing outdoors. Despite the high prevalence, we're not seeing the sort of massive hospital admissions and severe disease and deaths that we have seen. That's not to say that some hospitals are under pressure, because they absolutely are. And we've got loads more tools in our toolbox than we had even a year ago. And the bottom line is actually that the current approach is just unsustainable, and the public health impact of some of the interventions that we've been using just isn't really stacking up as it was before. I'll just flick over that bit actually. So I think one of the things that I wanted to cover really was the changes to testing, because that's the thing that's been in the media the most. And there have been massive changes to the testing programme. Obviously the free testing for the general public ceased on Thursday, and we've moved towards a strategy which is orientated around more targeted testing. So we can think of the testing in terms of testing for care, testing to treat, and testing to protect. So I've just highlighted in that slide what that actually means. But in terms of testing for care, we're using a mixture of PCR and lateral flow tests to both identify asymptomatic infection and symptomatic infection. So we're testing in hospitals, in community and primary care to support clinical decision making. There's been a bit of a shift in the use of lateral flow tests from asymptomatic testing to symptomatic testing, and we're also testing on admission, in advance of admission, and on discharge into other care settings. Test to treat is around ensuring that those individuals in our communities who are at higher risk, so people who have got certain types of cancer or who are immunosuppressed for whatever reason, can test when they're symptomatic in the community, and that will enable them to access antivirals and monoclonal antibody treatments, which we know can prevent more severe disease in those more vulnerable individuals. And the third bit is around test to protect. So this is about symptomatic and asymptomatic in high risk settings where we see both vulnerable individuals and where the risk of transmission is high. Also lots of questions about surveillance and, where are we going to get our information from now that testing has changed? Well, we've still got quite a bit of information out there, so we're going to continue with the ONS survey. So that's going to continue to focus on different geography, different ages and race. It is retrospective, so it's sort of about a week or 10 days behind what's actually happening at the moment. So the latest survey data was for the week up to the 26th of March, and that's telling us that in England about 1 in 13 people would have tested positive if they'd had a PCR test. That's up from 1 in 16 the previous week and 1 in 20 the week before. So we are still seeing increased rates, but the rate of increase is slowing. In Northumberland, it's about 1 in 15. That ONS survey only covers, it covers people in the community, so living in households in the community. So it doesn't cover care settings and it doesn't cover healthcare settings. But we do have these other two studies, the Vivaldi study and the Siren study, which looks at different aspects of infection in those two settings. We're going to still have ongoing testing in hospitals and other settings, which is going to provide us with some genomic sequencing data. And just as importantly, actually, we've still got those strong networks with other countries. The only reason why one of the reasons why we picked up the South African variant so early was because of those strong networks that we have with public health agencies in Africa and South Africa and other countries. So obviously the advice to the public is changing because we are moving away from advice which is COVID specific and moving towards more general advice around respiratory infections in general. And that's really important because the reason why we saw a downturn in flu and a whole host of other respiratory diseases over the last winter was because of those simple actions that we can all take to reduce infection. So the advice to the public is very much about getting vaccinated, about letting fresh air in, about continuing the basics, so hands, face, space, and about choosing to wear a face covering, particularly when the prevalence is high and you're going to be mixing with people who you wouldn't normally mix with or people who are particularly vulnerable. And then there's also quite a significant change in terms of the expectations of people who are symptomatic with respiratory infections in general. And actually, again, we're moving away from just focusing on having a high temperature cough and loss of taste and smell to asking people to work at home or stay away from work when they have a much wider range of respiratory symptoms. And if you do test and you test positive, then the guidance is encouraging people to stay at home until 5 days after that test result has come back. And there's also a whole host of guidance there about how you minimise the risk of spread. So advice about what you can do if you have to leave home, and advice about how you can reduce spread within your own household. I think that the most important thing for this meeting really is about how we're going to change our management going forward. So we are reverting back to the arrangements that we had pre-COVID, to one where our local health protection lead will lead on outbreaks in high-risk settings. And that management could be anything from sending out standard advice to setting up an outbreak management team meeting. And that's exactly the same arrangement that we had before the pandemic started. More locally, we've been operating, nationally, we've been operating within this contain framework, and the contain framework has been the framework that we've used to sort of link together the local, regional and national public health network. The contain framework required us to have a very comprehensive and long local outbreak management plan. It required us to have a COVID-19 control board, and because the contain framework is going to go and has been largely replaced by the Living with COVID document, the proposal is that we no longer continue to update that COVID-specific local outbreak management plan, and that we stand down the Health and Wellbeing Board's role as the COVID-19 control board. But what we would want to maintain is the Health Protection Board. The Health Protection Board has been really effective in terms of supporting pandemic management. It's been meeting every week or every fortnight for the last 18 months. It includes representation from CNTW, from the Northumbria Trust, from the CCG, from various individuals across the local authority. And the proposal is that we continue to have a health protection board, but we broaden the terms of reference to reflect health protection more generally, to focus on infectious disease management more generally, healthcare acquired infections, immunisation uptake more generally in the assurance of cancer screening programmes, and that very much reflects what has been happening in some local authorities before the pandemic. And obviously part of the role of the Health Protection Board will also be to plan our response to future variants and any future pandemic. I think the pandemic has presented us with a lot of opportunities. So from a vaccination programme point of view, lots of opportunity to apply the good practice interventions that we put in place to increase uptake in underserved communities, and we're looking at how we can apply those to other programmes. So how can we use trusted voices? How can we use health champions to increase uptake in those other programmes? Infection prevention control, that's something that's worked really well. We worked hard with the adult social care team, the public health team, the CCG, the Trust infection prevention and control team, with care homes and domiciliary care providers to improve IPC in those settings. And we really want to continue to maintain those relationships and ensure that those high levels of IPC continue, because of course they prevent all sorts of other infections that cause outbreaks in care homes, so norovirus, RSV and a whole load of other infections. I think there's also an opportunity to develop an IPC strategy which covers care settings, schools and workplaces. I think we've got some a bit of culture change to do, particularly in workplaces, to really shift away from a culture of presenteeism, which has a much bigger impact on productivity than absenteeism. In fact, the estimate is that for every day lost through absenteeism, 1.5 days are lost through presenteeism. I've already talked about the Health Protection Board and the need to retain that. And then there's also the opportunities which we're continuing to exploit about working across the LA7, and in fact we're working across the whole of the North East as Directors of Public Health on the inequalities agenda, looking at what we can do at scale. I think nearly finally from me, communications are really important. I think if they need to resonate, and they are definitely trusted more if they come from the NHS and potentially us as a local authority. They need to be simple. They need to be consistent. They need to explain to people why we're making the changes that we're making. And for us, I think the behavioural insights work is really important, because we need to understand from the perspective of different communities, what's in it for them. So if we want people to take up vaccination, what's in it for them if they take up that offer? And those behavioural insights, that behavioural insights work helps us to answer that question. So just finally then, a few key messages really. So I think the next couple of years are going to be quite bumpy. We can expect further waves of infection. Those waves of infection won't necessarily be less transmissible or less severe than the ones that we've seen. Vaccination is still really important, and the reason why Omicron in the UK is associated with mild illness and relatively low levels of hospitalisation and severe disease and deaths is because of the vaccination programme. And we are probably going to need regular, if not annual, vaccination. So maintaining high levels of that is going to be really important, but also a challenge. We've got to remember that those waves can happen really quickly. So as local authorities, we need to be prepared to respond equally quickly if that's required. That could mean supporting mass testing, mass vaccination. We could be asked to implement, to set up contact tracing again, and take on that outbreak response responsibility again. And then I think finally, probably the most important thing is about continuing to emphasise the importance of those safety behaviours. That's really vital, and that needs to work alongside trying to establish some behaviour changes like staying off work when we're unwell. So I'll hand over to Rachel, whose name I didn't forget.
Thank you. Thank you. I will be brief. I know it's been a long meeting. So just an update on the vaccination programme for you. So our performance remains really strong. So I can share these slides with you afterwards, because I appreciate that you didn't get those, so you can have a closer look at that. I won't major on that, but we are still performing very well. The next challenge for us is what we're going to be doing next, our next 3 priorities, which is really to continue to vaccinate. So the Evergreen offer is available to all eligible groups. We absolutely know we've got an autumn programme to deliver, and we also need to build a plan to do that at pace if that was required. We are just starting and have just started on the 21st of March the Spring Booster programme, and this booster is for our most vulnerable groups, so the over 75s, residents in care homes, and the individuals who are immunosuppressed. This will be delivered by our normal primary care community pharmacies, as well as the vaccination centres via the national booking system. And we've also got additional capacity with our roving model, which we will also be using for that. The 5 to 11-year-olds are also just starting to be offered a vaccine. That started on the 2nd of April, as well as that constant evergreen offer just to continue to vaccinate. Children will be offered Pfizer, but a third of the adult dose. And again, this is via the national booking system or local booking through primary care. And the evergreen offer, as I've mentioned, just needs to keep going. And we work with the Northumberland Vaccine Equity Board just to make sure that we are reaching as many people as possible with that offer. We know that there will be an autumn programme for the winter, which we will try very hard to co-administer along with flu. But we obviously don't know what is coming with regard to that from a point of view of we will wait for the JCVI, the Joint Committee for Vaccinations, to tell us which cohorts we will be vaccinating for that. But we are being asked to prepare for plans to make sure we have capacity in which to deliver that. And in addition to delivering that programme, we also need to be able to deliver that at pace, and obviously this year that the programme was speeded up quite considerably, so we will have plans to deliver that programme within 2 weeks as well, which will mean that we will have to look at sort of additional models, pop-ups, and again we'll work closely with the local authority to look at venues and work with them, which we've done very well throughout this campaign. And equally, as CCGs become the ICS, we will be feeding in so that they will ultimately hold the plan for those for vaccinations, again working obviously with places and local authorities, covering the areas on the bottom of that slide around inequalities and access and all the things that we've learned through the programme. So that's really all I wanted to say, but I suppose the key message is, you know, please wait to be invited for your vaccine. The national team and the media still put information out before we necessarily respond locally. That's still how we kind of hear some of that information. So I know that that does cause some confusion at times, but those eligible groups will get called by the local primary care community pharmacies. So do wait and you will get called. Nobody will be missed. Thank you.
Thank you. Thank you to Liz and Rachel. Thank you. I'm not going to take questions on this item as there are people waiting to come into the next meeting. If you've got any particular questions, can you let Chris have them and he'll pass them on to Liz. The next item on the agenda will be the work programme. There's nothing to comment on that, and I've no other urgent business. So I'll close the meeting. Can we stop the live stream, please?